Good morning everyone. Today I will be presenting my topic on the introduction to oral and maxillofacial biomechanics, how the biomechanics plays a role in the oral cavity and how the forces act on the various oral and maxillofacial structures. So coming to the basics of biomechanics, we already know that biomechanics is the application of the mechanical forces that are generated to the biological systems. Specifically, we will be dealing with the oral and maxillofacial complex in this seminar. So it explores the forces acting on the craniofacial skeleton, the hard tissue teeth, temporomandibular joint and the associated musculature. How these structures adapt to or resist to the forces altered by mechanical stresses and strains. We will look into it. And what are its clinical relevance in prosthodontics, orthodontics, oral surgery, implantology for trauma management and various cases. So coming to the history of biomechanics, how it came into play in general and for the oral and maxillofacial structures as a whole. So it dated back to as early as 15th to 19th century, in which Leonardo da Vinci in 1452 to 1519 made some of the first anatomical sketches of the skull, jaw and the masticatory muscles, hinting at the mechanical function. Galileo in 1638 and later scientists introduced principles of mechanics and material strength, laying groundwork for the initial application of physics to biological principles. And Julius Wolff in 1836 formulated the Wolff's law, showing that bone remodels in response to mechanical stresses, a principle which is still central to the biomaterials, orthodontics, implantology and craniofacial biomechanical outcomes. Second comes how the functional adaptation and the growth theories developed for biomechanics. So in the late 19th to early 20th century, Wilhelm Rauch introduced the concept of the functional adaptation, suggesting that the craniofacial structures remodel under the various mechanical influences and forces. This period also saw a comparative anatomic studies by Hubert von Meyer to explain the differences in the craniofacial mechanics across all species. And these ideas formulated the foundation for later orthodontic growth principles and adaptation theories and growth of the maxillofacial structures. Also coming to the biomechanical principles in the maxillofacial surgery, which was adapted in the mid-20th century. The first was the introduction of the osteosynthesis principle by Kruger and Campi. They developed the biomechanical principles of fracture lines and fixation, specifically Campi's line for osteosynthesis. These concepts sharpened the modern treatment of the maxillofacial trauma and the default fractures. And prosthodontic and restorative dentistry began considering force distribution as a basic occlusal design and prosthetic rehabilitation. Then comes the computer-aided biomechanics model, that is in the late 20th century till present. Introduction of finite elemental analysis was done in 1970s, and it revolutionized the craniofacial biomechanics by simulation of the stress and strain in teeth, various bones, TMJ and implants. 3D imaging technologies such as CBCT and MRI integrated with digital modeling improve the accuracy of the predicting of the mechanical structures and the behavior of the craniofacial structures. Also, current trends include personalized biomechanics, 3D printed implants, TMJ prosthesis and biomechanically guided tissue engineering concepts. So we will be going through in detail about the fundamental biomechanical concepts. So every system has been developed through the physics forces or the principles of the various force systems. That is the force, that is the push or the pull acting on the body, movement, tendency of the force to cause any rotation or any movement, and stress, force in per unit area, and strain, deformation per unit length. These are the basic terms that we need to know. Also comes into play is the viscoelasticity, that is the combination of elastic and the viscous, that is the time dependent responses, crucial in the temporomandibular joint disc management and periodontal ligament management surgeries. So coming to the next topic, that is the craniofacial skeleton biomechanics, specifically how the craniofacial system works under the biomechanical principles. So it serves as a composite structure with curved thin walled bones forming arches and buttresses that dissipate stress in the system. So the key stress bearing buttresses in the vertical are nasomaxillary, zygomaticomaxillary, pterygomaxillary, and for the horizontal are the supraorbital and the infraorbital ribs. For these, the clinical application is in the understanding of the fracture patterns, specifically for the management of the Lee-4 classification system of fracture management and designing fixation strategies in the maxillofacial trauma. How the load transmission pathways takes place in the craniofacial complex is the craniofacial skeleton behaves like an architectural framework where masticated and tomatic forces are transmitted along the buttresses that I talked earlier. These pathways help prevent localized stress conditions towards the cranial base. For example, the bite forces applied at the molars are transmitted through the zygomatic buttresses into the cranial wall. Also, how the fracture mechanics and the weak zones work, areas between buttresses, that is the orbital floor, nasal bones, maxillary sinus walls are structurally weaker, and they are more prone to fracture under stress. So this explains why the Lee-4 fracture occurs in this predictable place. And biomechanical understanding of this leads to guides to the reduction of the fixation principles in oral surgery, ensuring that the surgical plates are placed along the buttresses for optimal stability. So coming to the clinical relevance in reconstruction and implantology, rigid fixation techniques are aligned with the biomechanical stress bearing areas. In implantology and orthodontic surgery, knowing how forces travel through the craniofacial skeleton play a role and allow the surgeons to design the various specific implants, grafts and osteomechanics that mimic the natural stress pathways, reducing complications and ensuring long-term success. Coming to the biomechanics of mastication, the mandible acts as a class 3 lever system where the fulcrum is an EMJ, effort is the masticatory muscles and the load is the teeth or the bolus that we have. So muscle force vectors, that is a masseter, temporalis, medial and the lateral pterygoid, create complex pattern of compression, shear and torsion. Bite force distribution depends upon the occlusal contact between teeth and the EMJ biomechanics, and the advanced analysis in this area are being used for finite elemental modeling to stimulate stress and strain during mastication and prosthetic implant loading. Now coming to the temporomandibular joint biomechanics. So we already know that the TMJ is a inclinable arthromolar joint, combines hinge and sliding movements both, and for movements include rotation in the inferior joint space and translation, which is caused by the superior joint space. Articular disc, it distributes stress, resists compression, adapts to functional loads, and load distribution is done by the teeth forces that occur in the lateral pole of the condyle. This in dysfunction, that is the disc displacement or the arthritis, it alters the load bearing and may accelerate the degenerative changes. So we have to do the therapy accordingly. Oral and maxillofacial biomechanics in clinical practice, specifically integrating all the branches of dentistry. Orthodontics focuses control force application for bone remodeling. Implantology focuses on stress distribution for implant geometry, surface and bone density. Prosthodontics focuses on the occlusal design that must consider load vectors to prevent overloading of the TMJ and the supporting structure. Trauma surgery, rigid versus semi-rigid fixation is chosen based on the biomechanical stability which is required. And reconstruction, vascularized bone grafts and alloplastic TMJ prosthesis require biomechanical compatibility. Now coming to the summary, the oral and the maxillofacial biomechanics integrates the mechanical principles with the biological behavior of the craniofacial tissues. It provides a foundation for understanding the mastication, occlusion, TMJ function and the fracture mechanics in implantology and reconstructive surgery. Advanced computational models, as I discussed, that is the finite elemental analysis and the kinematic studies, are bridging the gap between the basic science and the clinical application to provide therapeutic outcomes in the various deformities. Thank you.